Have you ever noticed those subtle shifts as you age? Maybe needing the bathroom a bit more often, or, the flow isn't quite what it used to be. For lots of men, these things kind of creep up, and it's easy to just think, it's just part of getting older. But what if those little annoyances are actually signs of something really common, something manageable, and thankfully very treatable? Today, we're pulling back the curtain on exactly those symptoms. Let's unpack this.
Yeah, we're diving deep into benign prostatic hyperplasia, or BPH. Most people just call it an enlarged prostate. We'll look at causes, the impact, and crucially, the huge range of treatments available to you now.
Yeah, and our mission for this deep dive is really to distill the most vital info from a whole stack of sources, medical research, health guides, you name it. We want to give you a clear, comprehensive picture without all the usual information overload. The idea is to empower you so you can navigate potential treatment decisions with confidence, whether that's simple lifestyle changes or maybe even these newer cutting-edge procedures. Okay, great. So let's start right at the beginning. What is the prostate exactly? It's this walnut-shaped gland, right? Sits just below your bladder. Part of the male reproductive system, adds fluid to semen. And here's the interesting bit I found. It has two main growth spurts. It doubles in size when you're a teen, and then after about age 25, it just keeps growing for the rest of your life. Is that continuous growth the real issue with BPH?
That's exactly it. That growth after 25 is the core of the problem. Benign prostatic hyperplasia, BPH, that's when the growth becomes, excessive, and it's incredibly common. We're talking up to half of men between 51 and 60. And get this, by the time you're over 80, it could be as high as 90%. 90. As it gets bigger, it literally starts to squeeze or clamp down on the urethra, that tube carrying urine out. Yeah. And that restricts the flow.
Okay, and that restriction, that's what causes all those annoying symptoms. The ones called lower urinary tract symptoms, or LUTS. They can really mess with your day-to-day life, can't they? Like needing to pee urgently or really often, or waking up loads during the night, nocturia, is that it? Even sometimes not making it in time, the urgency incontinence?
Precisely. Those are the storage symptoms, and then you have the voiding symptoms.
Fine.
Things like trouble actually starting the stream, what we call hesitancy, or the stream itself is weak, or it stops and starts. Straining to go. Right.
Intermittence. And then even after you think you're done, that frustrating dribbling or feeling like, hang on, the bladder isn't actually empty, those post-micturition symptoms.
Exactly. And it's really crucial here to address a big worry many men have. They hear prostate and symptoms, immediately think cancer. But the benign in BPH specifically means not cancer. It's non-cancerous growth. BPH doesn't lead to prostate cancer, and it doesn't increase your risk.
Okay, that's a relief.
But and this is important, some symptoms can overlap. Age is a risk factor for both, for instance. So, are there initial signs that might hint one way or the other, or is it really down to the doctor's tests?
That's such a vital point, and it really underscores why seeing a doctor is key. Diagnosis does involve specific things, like the PSA test, usually more for cancer screening, or a digital rectal exam, the DRE, which can check for enlargement or abnormalities. But knowing the risk factors for BPH can help you be more aware. Aging is the big one. Like you said, it's rare before 40. Family history matters too. And interestingly, general health conditions seem linked to things like diabetes, heart disease, even obesity.
Yeah, our overall health really does seem connected.
So if the symptoms are there, but maybe not too bad, what's the first approach?
Well, if symptoms are pretty mild, not really bothering you much, a perfectly valid option is what we call watchful waiting. Yeah, that doesn't mean ignoring it. It means regular checkups, maybe annually, just to monitor things, see if anything changes. No active treatment yet, just keeping an eye on it.
Right, okay. And alongside that, there are some simple lifestyle things you can do, practical changes.
Absolutely. These can make a surprising difference for some men.
Like cutting back on fizzy drinks, alcohol, caffeine, artificial sweeteners, because they can irritate the bladder.
Exactly. Reducing those can help calm things down.
And what about fluids? I read something about drinking less in the evening.
Yeah, that's a good tip, especially a couple of hours before bed. It can really cut down on those nighttime bathroom trips, the nocturia we mentioned. But critically, don't dehydrate yourself. Keep drinking fluids earlier in the day.
Makes sense. And double voiding, what's that?
It's simple, really. After you urinate, just wait a moment or two, relax, and try to go again. Helps make sure the bladder is as empty as possible, but don't strain or force it.
Good tip.
Yeah.
And planning ahead before long trips.
Always wise. And managing constipation is another one. Increasing fiber intake helps avoid that extra pressure on the bladder.
These really sound like straightforward, everyday changes, things you could start doing right away.
They are. And for some men, they're enough to significantly improve their quality of life without needing anything else.
What about medications someone might already be taking? Can they affect things?
That's a really important point. Definitely review your current meds with your doctor. Certain drugs, some antidepressants, decongestants, even common antihistamines like diphenhydramine, the one that makes you drowsy, they can actually make urinary symptoms worse. Your doctor might be able to suggest alternatives.
Interesting. And I also saw something about bladder training, like exercising your bladder.
Yeah, you can think of it like that, a sort of bladder boot camp. It's a structured program to help you gradually increase the time between needing to urinate and help your bladder hold more. Often involves timed voiding schedules, breathing techniques, relaxation, muscle exercises. Sometimes people keep a chart to track progress.
Okay, now, what about natural remedies? There's a lot of talk about things like saw palmetto. Do they actually work?
The natural remedies question. Look, there's a lot of interest, but the scientific evidence is often, mixed, or even disappointing. Take saw palmetto. It's been used traditionally for ages, and some small early studies looked promising, but then larger, better designed studies came along and found it was basically no more effective than a placebo, than a sugar pill.
Really? So all that hype?
Pretty much, for saw palmetto at least. Others like beta-sitosterol, PGM from African plum bark, ryegrass pollen. Some small studies show potential symptom relief, but the evidence isn't super strong or consistent, and long-term effects often aren't well known.
Any dietary links?
There's some interesting research. One study suggested that a diet high in fruits and vegetables, especially things like dark leafy greens and tomatoes, might be linked to less BPH or fewer symptoms. Vitamin D deficiency and obesity might also play roles.
But there's a big caveat here, isn't there, with supplements?
A huge one. This really raises a critical point. Just because something is labeled natural doesn't mean it's automatically safe or effective. Crucially, the FDA doesn't regulate herbal supplements for quality, purity, or even if they contain what they claim. So the absolute bottom line is, talk to your doctor before trying any natural remedy. They can interact with other medications or have side effects you don't expect.
Right, okay. So if lifestyle changes and maybe these natural approaches aren't quite cutting it, what's the next step? Is that when medication comes in?
Generally, yes. Pharmaceutical interventions or medicines are now the most common way we treat mild to moderate BPH symptoms. It's a big shift from years ago when surgery felt like the main option after watchful waiting. There are many more choices now.
So what's the first line of medication, usually?
Often, it's a class of drugs called alpha blockers. These work by relaxing the smooth muscles, specifically in the bladder neck and the prostate itself. This opens up the channel, making it easier for urine to flow.
Okay, so they don't shrink the prostate.
No, that's key. They don't shrink the prostate. But they can offer pretty rapid symptom relief sometimes within just a few days, maybe a week.
What are some common ones?
You might recognize names like tamsulosin, brand name Flomax is very common, or alfuzosin, sialidosin, doxazosin, terazosin. They're generally effective, but they do have potential side effects. Things like dizziness, sometimes fainting, headaches, maybe low blood pressure. Especially with the older ones like terazosin and doxazosin, doctors often have to start with a low dose and increase it gradually.
And what about that other side effect, retrograde ejaculation?
Yes. That can happen. It's where semen travels backwards into the bladder during orgasm instead of out through the penis. It's physically harmless, but obviously it's an important consideration for men who are concerned about fertility or just find it bothersome.
And there was something about cataract surgery, too.
Right, very important. Alpha blockers can cause a condition called intraoperative floppy iris syndrome during cataract surgery. So if you're on these meds and need cataract surgery, you absolutely must tell your eye surgeon beforehand. They can take precautions.
Okay, so alpha blockers help the flow quickly but don't shrink the prostate. What if you do need to shrink it, especially if it's quite large?
Exactly. That's where the next class of drugs comes in. 5-alpha reductase inhibitors, or you'll hear them called 5-ARIs. These work completely differently. They actually block the production of a hormone, dihydrotestosterone, or DHT, which is a key driver of prostate growth.
So they tackle the root cause, the growth itself.
Precisely. By blocking DHT, they can actually shrink the prostate gland over time. This makes them particularly helpful for men with significantly enlarged prostates. And they can also reduce the risk of BPH complications down the line, like urinary retention, and potentially reduce the need for surgery later on.
They work more slowly.
Yes, that's the trade-off. You won't feel the effects in days like with alpha blockers. It typically takes several months, maybe 4 to 6 months, to see the full benefit as the prostate gradually shrinks.
What are the main drugs in this class?
There are two main ones, finasteride, brand name Proscar, and dutasteride, Avodart. Dutasteride is considered a bit more potent as it blocks both types of the 5-alpha reductase enzyme, leading to a more significant drop in DHT levels compared to finasteride.
And side effects for these?
They can include sexual side effects for some men, things like erectile dysfunction, decreased libido or sex drive, also retrograde ejaculation. Rarely, some men might experience breast tenderness or enlargement called gynecomastia.
Now, there was that FDA warning associated with these drugs, wasn't there? Something about prostate cancer risk. That sounds concerning.
Yes, it's important to discuss that. The FDA issued a warning noting that while 5 ARIs can reduce the overall risk of developing prostate cancer, studies showed they might be associated with a small increased risk of developing a more aggressive, high-grade form of prostate cancer in the men who do get diagnosed.
So what does that mean for someone considering these? How do doctors handle that?
It means very careful discussion and shared decision-making. The doctor weighs the significant benefits of shrinking the prostate, improving symptoms, preventing complications against this potential, though small risk. It also highlights the importance of ongoing monitoring. And another key thing, these drugs lower your PSA levels, the prostate-specific antigen blood test often used for cancer screening. They typically cut the PSA level by about 50% after 6 months or so. So doctors need to be aware of this and mentally double the PSA reading for accurate interpretation when screening for cancer in men taking these drugs. Close follow-up is essential.
Okay. Then there's another class, the ones also used for ED.
Right. Phosphodiesterase 5 inhibitors, or PDE5 inhibitors. Most people know them as drugs for erectile dysfunction. But one of them, tadalafil brand name Cialis, is actually FDA approved at a low daily dose to treat BPH symptoms too. It works by relaxing smooth muscles in the bladder and prostate, similar in some ways to alpha blockers.
So that could be a good option if a man has both BPH symptoms and ED?
Exactly. It can tackle both issues with one pill, which is obviously convenient. Side effects are generally mild headaches, back or muscle pain, flushing, stuffy nose, that sort of thing.
And sometimes doctors combine medications.
Yes, combination therapy is quite common, especially for men with larger prostates and more significant symptoms. The most typical combo is an alpha blocker plus a 5 ARI. There's even a single pill available called Jalin that contains both dutasteride and tamsulosin.
What's the advantage there?
You get the rapid symptom relief from the alpha blocker, while the 5 ARI works over the longer term to shrink the prostate. Often, the goal is that after about 6 to 9 months, once the 5 ARI has had time to work and shrink the prostate, the alpha blocker might potentially be stopped.
But more potential side effects, I guess?
That's the trade-off, yes.
Yeah.
Taking 2 drugs means you could potentially experience side effects from either or both. It's always a balance.
Okay, so that covers the main medication routes, but what happens if those aren't enough? Or if someone develops complications like not being able to pee at all or getting kidney issues?
That's when the conversation usually shifts towards intervention, towards surgical options. If lifestyle changes and medications haven't provided sufficient relief, or if complications arise like acute urinary retention, suddenly being unable to pee, kidney damage from back pressure, recurrent bladder stones, or frequent UTIs, then procedures become important considerations.
And surgery for BPH isn't just one thing anymore, is it? I remember hearing about TURP, but now there seem to be newer, less invasive options.
Absolutely. The field has evolved significantly. Not too long ago, TURP was the mainstay, but now we have a whole category of what are called minimally invasive surgical therapies, or MISTs.
MISTs? Okay, what's the big idea behind those?
The core principle is to effectively treat BPH symptoms, but with less impact than traditional surgery. They typically involve using smaller instruments inserted through the urethra, or sometimes small needles. There are usually no large external cuts. This generally leads to faster recovery, less pain, fewer risks like heavy bleeding, and often a key goal is preserving sexual function, both erections and ejaculation.
So what are some examples of these MISTs? I've heard of UroLift.
Yes, UroLift, technically called prostatic urethral lift, or PUL. This is quite unique. It doesn't involve cutting or heating tissue. Instead, tiny permanent implants are placed to physically lift and hold the enlarged prostate lobes apart, like tiebacks on a curtain, opening up the urethra.
No cutting or heating. That sounds less traumatic.
It generally is. Benefits include rapid symptom relief, often a very quick recovery. Patients might be back to normal activities in around 10-11 days. And importantly, studies show it has a very high rate of preserving both erectile and ejaculatory function. One major study showed 100% preservation at 2 years.
Wow. Can it be done easily?
Often, yes. It can frequently be done in a urologist's office or a day surgery center, sometimes under local anesthetic or light sedation, though general anesthesia is also an option. Post-procedure catheter use is often minimal or not needed at all compared to some other procedures.
Any downsides? Does it last?
Well, like any procedure, it's not guaranteed forever. There's a retreatment rate, maybe around 13-14% of men need another procedure within 5 years. But overall, it's a very popular missed option, especially for men prioritizing sexual function and fast recovery.
Okay, what else is in the missed category? Rhesum.
Right, Rhesum, which is water vapor thermal therapy, or WVTT. This uses sterile water vapor, basically steam. A small probe delivers targeted bursts of steam into the excess prostate tissue. This energy destroys the targeted cells, and the body then gradually reabsorbs the treated tissue over the next few weeks and months, shrinking the prostate and opening the urethra.
Steam, huh? Does that preserve sexual function too?
Yes. Studies show Rhesum also has good rates of preserving both erectile and ejaculatory function. Like UroLift, it can often be done in an office setting under local anesthetic. Symptom improvement typically becomes noticeable within a few weeks, with maximum benefit usually around 3 months, and studies show the results can be durable for at least 4 to 5 years.
Any considerations with Rhesum?
One thing is that post-procedure catheter use is much more common than with UroLift. Maybe around 90% of men need one, typically for an average of about 3 days, while the initial swelling goes down. The retreatment rate might be slightly higher than UroLift in some studies too.
And there's another one using water, Aquabeam.
Yes, Aquabeam robotic system, which performs robotic water jet treatment, or RWT. This is pretty high tech. It uses a robotically controlled, heat-free water jet to precisely remove prostate tissue. The surgeon maps out the area using real-time ultrasound imaging, and then the robot executes the removal very quickly and accurately.
Robot water jets. Sounds intense. Office procedure?
No, this one requires general or spinal anesthesia, so it's done in a hospital operating room setting, not the office. Early results look promising for symptom relief, but compared to UroLift and Rhesum, there's less long-term data available just yet on durability and retreatment rates. There can also be a higher risk of bleeding compared to the other mists, though generally less than TURP.
It's fascinating how these newer options are being directly compared now, looking at patient experience. What does that tell us?
It tells us that the best mist really depends on the individual patient's priorities. For instance, some head-to-head comparisons suggested UroLift might offer better initial quality of life scores and definitely lower rates and duration of catheterization compared to Rhesum. Patient satisfaction was very high with UroLift. But Rhesum also has excellent outcomes and might be preferred by some. Aquabeam offers very precise removal, but requires anesthesia and has less long-term data. It really highlights the need for that personalized discussion with the urologist.
Okay, so those are the mists, but the traditional surgeries are still around, like TURP.
Oh yes, transurethral resection of the prostate, or TURP, is still considered a gold standard by many, simply because it's been around for decades, and we know it's highly effective at relieving symptoms long-term.
How does it work again?
An instrument called a resectoscope is inserted through the urethra. It has a camera and an electrical loop that the surgeon uses to cut away and remove the excess prostate tissue piece by piece, opening up the channel.
Gold standard. Yeah. But there are downsides, right? Why aren't more people choosing it?
Primarily because of the higher risk of complications compared to mists. The big one is ejaculatory dysfunction. Retrograde ejaculation is very common after TURP, maybe affecting 65% or more of men. There's also a higher risk of bleeding requiring transfusion, infection, UTIs, and though rare, potential for urinary incontinence. Recovery is also longer than with mists, usually involving a hospital stay and a catheter for a few days. Because of these trade-offs, studies suggest only about 2% of men with moderate to severe BPH actually opt for TURP these days, given the newer alternatives.
Are there other traditional style surgeries besides TURP?
Yes, a few others, though less common now. Transurethral incision of the prostate, TUIP, is for smaller prostates. It involves making small cuts in the prostate neck to relieve pressure, rather than removing large amounts of tissue. Less risk of retrograde ejaculation than TURP. Then there's laser surgery. Various types exist, like green light laser, PVP, or HOLEP, holmium laser enucleation. These use laser energy to vaporize or remove prostate tissue. HOLEP, in particular, can remove very large amounts of tissue effectively, similar to open surgery but through the urethra. It requires specialized training, though. And for very, very large prostates, or when there are other complications like large bladder stones, sometimes open prostatectomy is still needed. This involves an external incision, usually in the lower abdomen, to remove the inner part of the prostate. Nowadays, this can sometimes be done laparoscopically or robotically, using smaller incisions, which can speed up recovery compared to traditional open surgery.
So it really is a spectrum. The more invasive surgeries offer very effective, often permanent relief, but definitely come with those higher risks and longer recovery times. It's a major trade-off to consider.
Exactly. Balancing the degree of symptom relief needed versus the potential side effects and recovery impact is key.
Which brings us back to the patient's role in all this. How important is it for someone to be involved in deciding which route to take?
It's absolutely paramount. The concept we talked about earlier, shared decision-making, is central here. The official 2021 guidelines from the American Urological Association strongly emphasize that doctors should discuss all the relevant treatment options, watchful waiting, medications, all the different mists, traditional surgery, and clearly lay out the specific risks and benefits of each one as they relate to that individual patient. It's not about the doctor just telling you what to do, it's a conversation.
Right. So how do you make the best choice for your body, your life? What factors should you be thinking about and discussing with your doctor?
You need to consider several things together. How severe are your symptoms? How much are they actually bothering you? What's the actual size and shape of your prostate? That can influence which procedures are suitable. What's your overall health like? Can you tolerate anesthesia if needed? A big one. How important is preserving sexual function, both erections and ejaculation, to you? Different procedures have different risk profiles there. And practical things too. How much recovery time can you afford? What are your preferences regarding potential side effects? It's putting all those pieces together.
And looking to the future, is anything exciting coming down the pipeline? Any way to make these decisions even more precise?
There's some really interesting research happening, particularly around biomarkers. Scientists are studying substances found in urine things with names like BDNF, NGF, PGE2 to see if they can act as indicators. The hope is that these biomarkers might eventually help predict how well someone's bladder is functioning before surgery, or even predict how likely they are to respond well to a specific type of treatment.
Wow, so it could help guide the choice even earlier and more accurately.
Potentially, yes. If we can connect this to the bigger picture, it's all moving towards truly personalized medicine. Tailoring the treatment not just to the condition, BPH, but to your unique individual body and how it's likely to respond.
So as everyone can hear, the landscape for dealing with an enlarged prostate is just incredibly varied now. We've gone all the way from simple lifestyle tweaks and different types of medications through these really innovative, minimally invasive therapies right up to the established traditional surgeries.
Yeah, it's complex. But the good news is there are more effective choices than ever before, all aimed at improving those bothersome symptoms and really boosting your quality of life.
It seems like BPH is common, maybe even inevitable for many men as they age.
It is very common, yes.
Yeah.
But the key takeaway is that the way we treat it is evolving rapidly. I think the real challenge now isn't just finding a treatment, because there are many good ones. It's about finding the right treatment for the right patient at the right time, and making sure it truly aligns with your personal health goals and what you expect for your quality of life.
That sums it up perfectly. Your health journey is absolutely unique. Understanding all these options we've discussed today is really your first crucial step towards making informed decisions that feel right for you. So please, if you're experiencing symptoms, go have that conversation with your doctor. They're your best partner in navigating these choices.